Now, did you know that COPD is the third leading cause of death worldwide, with the yearly expenditures exceeding $50 billion only in the US? I was really shocked to know about this. So what exactly is COPD? And specifically, what is acute exacerbating COPD? And what are the treatment guidelines in the clinical practice right now? So this is going to be our topic for today. My name is Nader Ashraf. Alongside my colleagues, we have Kassem Al-Assaad, Abou, Shaar, Amr Farahat, and Khabbaz. So let me start off. What is COPD? Chronic obstructive pulmonary disease. It is, bear with me the definition right now. It's a progressive, incompletely reversible, chronic airflow obstruction associated with an exaggerated inflammatory response, usually due to bacteria, due to viruses, or any pollutants. COPD is not a specific disease. It's a group of diseases that include but are not limited to emphysema, chronic bronchitis, or asthma. So, and all of these diseases are associated with usually the symptoms associated with these diseases include dyspnea, shortness of breath, and increased cough with sputum production. Now we have a fancy term for COPD, a specific case of COPD. It's called acute exacerbating COPD. It's just a fancy term to mean that the symptoms that I just said are just more severe. So you have very, very severe shortness of breath with a huge increase in coughing rate with a load of sputum. Okay? Now for the treatment in general. The treatment usually accompanied by bronchodilators. We have systemic corticosteroids. They are the first line treatment for COPD, specifically acute exacerbating COPD. All guidelines agree on this fact. Bronchodilators alongside systemic corticosteroids. However, the huge discussion right now we're having is about this, the dosage of corticosteroids along with the regimen to be followed. Now we're gonna start off the discussion of this topic with a scenario about how a clinical practice change occurs in daily life. So, yeah, we may begin.
Assalamu alaikum. My name is Dr. Abou. I'm an internal medicine specialist. Mr. Anas Khabbaz, right?
Yes.
How can I help you today?
I have this shortness of breath, and also I'm coughing a lot. This is affecting my daily life. I'm concerned about this.
I'm very sorry to hear that, Mr. Anas. How long has this condition been bothering you for?
For about a week or 2 weeks.
And what do you think may have caused this problem?
Well, I googled my symptoms and I feel like I have lung cancer. Yeah, and especially the fact that I lost like around 7 kilograms in the past month.
I'm very sorry to hear that, Mr. Anas. You lost 7 kilograms in the last month?
Yes.
Are you on any diet?
Yes.
Mr. Anas, do you smoke?
Yeah, I'm a smoker. I smoke.
Alright. I'm gonna listen to your breathing sounds if you would. Okay, inhale, exhale. Inhale, exhale. Mr. Anas, I understand your concern about having lung cancer. However, we need to do more tests in order to find out what's going on with you. So I'm going to schedule a few lab tests as well as an x-ray, and I'll see you in my office tomorrow, inshallah. Let me escort you to the lab. Thank you.
Hours later. We have a lot of work to do today. Oh. Doctor, Professor.
Sorry, Dr. Qasim?
Yes. Professor.
Dr. Qasim, I had this patient who came in yesterday with symptoms of a chronic obstructive pulmonary disease, and I suspected that he has emphysema. Would you please look at his X-ray with me?
Yes, you may show me the X-ray in front of me, please, because I don't have the allergy to the back. Okay, looks normal.
Yeah, I think they have. Now, Dr. Qasim, I heard that there were new management guidelines about the treatment of emphysema. You sent me 2 papers last week about the different durations of corticosteroid therapy for treating acute exacerbated COPD. I just wanted to know if you have any more information regarding these papers.
Actually, I've sent you these 2 papers, but I've been doing a bit more of some light reading concerning the treatment of COPD using steroids. Well, as I concluded and summarized these couple of articles, I've done a bit of 2 slides concerning about relating to the researchers. Well, we had a couple of researchers done regarding the low dose versus high dose administration of corticosteroids in acute exacerbating COPD. So in this research, we had a huge sample size, which was done recently, relatively recently, and it was basically a meta-analysis in the Clinical Respiratory Journal, talking about whether we should give low dose or high dose of corticosteroids, or whether there was a big difference between them or not. Well, 2 groups of patients were administered corticosteroids. One group was administered a low dose of corticosteroids, the other was administered a high dose on the occurrence of AE-COPD. The outcome was clinically significant because although mortality rate did not change between the two doses, however, the length of stay was decreased a lot. The costs, hospital costs, and the patient's bills were decreased, and the outcome was as effective, if not even better, than the high dose. Why would it be better? Well, first of all, we're giving a low dose, so the adverse effects were decreased greatly. And adverse effects may be very annoying and sometimes very harmful for the patient, including hyperglycemia, glaucoma, and even myopathies. Another couple of researches were done concerning the 5 days versus 14 days regimen for administering corticosteroids for the patients. So this was basically on the what was it called again? The Cochrane library. It was a systematic review involving approximately more than 200 researchers, where patients were split into other 2 groups also. A group was given 40 milligrams of prednisone per day for 5 days, and the other was given for 14 days. Now, the outcome of these randomized clinical control trials were very significant, where that the 5 days and the 14-day regimen were proven having equal effects on the patients. 5 days had less adverse effects, as we talked before, because of the decreased dosage. We're giving 10 days extra, giving 400 milligrams extra of corticosteroids caused a lot of adverse effects to be for the patient. However, the 5-day regimen proved as effective, if not even better, except in minor cases, some of which did not respond to the 5-day regimen, so they were given 14-day regimen, which was proved to be effective. And the patient compliance increased with the 5-day regimen, because the 5-day regimen decreased the adverse effects, and it was a short period of time, so patients were more likely to comply with the 5-day than the 14-day regimen. So there was response from the further light reading I've been doing.
Dr. Qasim, you said that the only difference was Professor Qasim. You said that the only difference between the 2 regimens was the mortality. The mortality rate was the same in both regimens. So why would you even change the clinical practice if they were the same?
Well, we're looking at the patient as a whole. We're not looking at the patient just at one aspect, mortality rate or something. So the patient as a human being had complied with the medicine, and was even the disease was the symptoms were improved and were dissolved by the 5-day regimen as equally as the 14-day regimen. Although some minor cases I've talked about, they did not comply, but those were like in small percentages, 1 or 2%. However, the majority of the patients complied much better with the 5-day regimen and استفادوا equally.
Okay. One more question, Professor Qasim. You said that this treatment was only for acute exacerbating COPD. What about if you use it for people who have mild or moderate COPD? Do we also give the same treatment to them?
Well, since acute exacerbating COPD have been coming to the ICU more often than the other mild and moderate patients, this is why the researches were done for acute exacerbating. However, mild and moderate cases of COPD are still under research, and we need further studies to prove such regimen and changes.
Thank you, Professor Qasim. I'm going to start my patient with the treatment, and let's go.
Okay, so our studies have shown that the usage of low dosage corticosteroids is not inferior to the usage of high dosage of corticosteroids. And this is in terms of hospital stay, hospital cost, and ventilation, and also adverse effects. Also, studies have tried to compare the 5 days regimen versus the 14-day regimen, and there's a controversy at this point because patients who were not compliant with the 5 days regimen and were compliant with the 14-day regimen were elderly patients, were also patients who were overtreated, and patients who are previously diagnosed with COPD. So we need further studies, not just to compare between the 5 days versus the 14 days regimen, but also to determine the optimum COPD dosage. Studies have also shown that the usage of high dosage of corticosteroids cause burden of chronic conditions, such as myopathies. It causes also decrease in bone mineral densities, and it causes also mental status health issues. Change, which is a main topic that we should discuss, because change in any practice is difficult, but change in a medical practice is hard. And studies have shown that for major change to occur in the healthcare system, it would take 6 to 8 years to occur. However, medical doctors are required or are obligated to acquire and to maintain the expertise needed to cure patients. Also, moreover, change is currently all around us, so we need to accept it, support it, be passive or participate in it. And with that, we'd like to conclude our presentation about steroids for COPD. This is probably. Thank you. Are there any questions?
And thank the group on behalf of all of you. Please ask questions. Okay? If you want to